But I don't love them, but they do have enough caffeine and vitamin B to keep me awake when I didn't sleep good. Okay, multiple sclerosis is the first concept I want to start with in immunity. In immunity in the previous semesters, can you hear me in the back? Okay, I usually have no problem with a big mouth. Immunity in previous semesters, you've studied infections, and you've studied mostly infections, right? Inflammation, a little bit of inflammation, some infections. In level 3 and level 4, we move on to some other things. This semester is largely autoimmunity, which means you're immune to yourself. And there's a lot of diseases that fall into that category. We also do the first of the exaggerated immunities, anaphylaxis. And we also do a very common but highly important disease to make sure you know it and it's anchored in your mind before you get to boards, tuberculosis. So the example as we do this time are several autoimmune disease plus TB and anaphylaxis. And so that's what we'll be covering the next couple of days. That being said, multiple sclerosis is where I'm going to start with the autoimmune diseases. I'll do the autoimmunes before we go forward to the other things. Okay? So you know where I'm at. I don't have a remote in here, so I'm a wanderer, but I have to manually push the slides forward, so I might wander and pick it, whatever. All right. Multiple sclerosis. This is, how many of you have heard of this disease? Most of you have. Back when I was growing up, nobody knew about this disease. Now lots of public awareness is out there, plus you guys are healthcare people, so you're kind of in the know. Multiple sclerosis, a chronic neurologic condition. This is a neurologic autoimmune disease. Okay? It's chronic, it doesn't go away, it has no cure, and we don't even know exactly why it occurs. The immune system is so complex, we're trying to figure out so much about it. Multiple sclerosis causes demyelinization. Myelin, AMP, right? AMP, I do a lot of AMP. Myelin is that fatty layer on the outside of the axons that enables a nerve transmission to be faster and more efficient. And what happens with this disease that we know happens is some initial insult, infection, immune suppression, something happens. And in the neurologic cells, the T cells become active and they start attacking the body. And T cells and B cells both get in on the game plan. The T cells start it off, and they get on the game plan and they attack their own neurologic cells. It starts with the myelin. It happens in the brain and in the spinal cord. This is a central nervous system problem. Out in the extremities, they usually have neurolemma instead of myelin anyway. It can rejuvenate and heal. Myelin heals really slowly and not always effectively, and a lot of times scars. So myelin destruction can turn into a chronic problem. All right? When you look at a picture of the brain, we talk about gray matter and white matter, right? Gray matter is the dendrites and cell bodies where the actual thinking and transmission of impulses starts. The white matter is the axons that transmit. Most of the damage with MS is in the white matter because it happens on the myelinated axons. Later in the disease, there's some gray involvement, and some MS patients have cognitive issues later in the disease. It doesn't usually start with cognitive issues. It starts with mobility issues and transmission of normal impulses. Okay? It's inflammatory. All exacerbations, it exacerbates and remits, which means it gets worse and then it gets better, and then it gets worse and then it gets better. So it exacerbates and remits. It's always inflammatory. The exacerbations are an inflammatory process where the T cells and B cells that have caused inflammation and the products that fight inflammation start attacking the cells, because that's what inflammation is. It's supposed to be going, ooh, something's wrong, let's kill it off and get rid of it. The problem is it thinks that your myelin is what needs to be killed off and be gone, and I really like my myelin. I don't know how you feel about yours. I'm attached to mine. All right, it's progressive, it's degenerative. Okay? I will tell you, I have multiple sclerosis. I've had it for 30-something years. Okay? But I'm the poster child. I've been bad, I'm doing good. So when we talk about these drugs, I can tell you all about this. All right, we don't know what caused it. We think it might be a viral infection that triggered it, might be Epstein-Barr, We don't know. How many people in our society get Epstein-Barr? Loads and loads and loads. We've tied it to mono, we've tied it to cancer, we've tied it to MS, we've tied it to lupus, we've tied it to so many things, and we're not exactly sure if that's what causes it, but it's highly suspicious that that's one of the things that causes it. MS is not inherited, but it is familial. So I don't carry an MS gene to pass on to my kids, but it comes in family clusters. And what we think is inherited is the immune response defect. So that let's just assume it was Epstein-Barr. That hit my brain, I got a bad Epstein-Barr infection, and I inherited our immune response that changed that response to an autoimmune response. We don't think that MS is what's contagious, or I pass MS through the genes, but I might pass that inability, that defective immune response in my genes. So my kids are more likely to get MS, but they didn't necessarily get it and may not ever get it, and it's real random. Right? What we know is that after the T cells and B cells, right, the lymphocytes are what produce antibodies, right? So once it says, ooh, the myelin is our enemy, you produce autoantibodies against your own myelin. So it breaks it down. So we have some primary event that caused the secondary immune reaction, right? So an infection, immune suppression, something happened. Secondary is their autoimmune response. Okay? Again, we don't know what triggers it. So what do we know is true about MS? We know that it's more common in people that live north of the equator. We also know the further north you go in our country, the more common it becomes. Isn't that interesting? We believe a vitamin D deficiency increases your risk. A lot of autoimmune diseases are tied to vitamin D deficiencies. So if you go further and further north, there's less sunlight during the winter, shorter days, right? It's a little cooler, people don't get out in the sun as much. Around the equator, people are in the sun all the time. The further north you go, a little less, right? So we think vitamin D has something to do with this. We also know that Epstein-Barr infection increased their MS risk. There is some evidence that a large percentage of people who have MS at some point either had a parasite or a dysbiotic, which means their bacteria in their gut became out of whack for a while. And so there's evidence that has happened to a lot of people who also have MS. Okay? Human lymphocytic antigen is what HLA stands for, human lymphocytic antigen. There's a couple of antigens, which are proteins on the surface of human lymphocytes. We know that there's a certain antigen associated with 20% of MS cases. That's not the majority, but it's weird that it's out there. HLA will also talk about an organ donation because HLA, those antigens we have to match to make sure organs aren't rejected. All right. People who smoke early in childhood are higher at risk. Smoking puts you at risk for everything. It's just kind of, you got to know. Is there a disease out there? Oh yeah, smoking caused that. Whatever. Adolescent obesity. This disease primarily affects young people. Its onset is at young people. Now, they're going to live to old age, so they have it all their life, but it starts in that 20, 30, 40, and then the older we get, the less new onsets there are. There are some cases that start late in adolescence, but the majority of cases start in their 20s and 30s.
Is this more of an onset disease, or more it's hereditary, or just either or?
We don't know. I have no one in my family that had MS. Nobody. Or that we know of. Could I have had a great-grandmother who had it and she just died younger and nobody talked about it? Possibly. But it's just kind of, I think what you're saying, it's an onset vibe. People will present with symptoms, have no idea. Then when we start talking to them, we go like, oh, I think my great-aunt had that, or my grandma had that. But it's not like, oh, I have MS, so my kids are going in to get checked for MS every year. So it's not like that. Okay? Women 2 to 3 times more often than men. So is there an estrogen link? Maybe. We don't know. I love diseases where we don't know. All right. So the Myelin has antibodies that attack it, which demyelinates the axon, right? A demyelinated axon then has slower, blocked, and distorted impulses traveling down the axon. So if my brain says, move, the message it sends may be real slow, or may go, okay, move, but move crooked, right? There were days I couldn't pass a drug test on the side of the road, and it has nothing to do with alcohol. I couldn't walk a straight line if I tried. But that's because I have distorted impulses. Okay? And then those distorted impulses lead to the signs and symptoms, because it's the nerve impulse traveling to their eye or to their leg or to their bladder or whatever it is that it's traveling to that causes the symptoms. Right? After that initial attack, that inflammatory exacerbation, there's a period of time that the nerve cells regenerate. The inflammation goes away, your body settles down, you regrow some myelin or you scar it over, and you have some remission of symptoms. Okay? The patient may get better, may get a little better, may get a lot better. I have been flat on my back in bed, unable to walk, with double vision, unable to get out of bed, okay, for 3 or 4 months at a time. And then I remit. And here I am, right? I'm walking around, I drive, I can see you, it's all a good thing. So, I mean, I'm not trying to tell you, I like to tell my story, because sometimes you learn about patients from a real person who has the disease. It's a good storytelling opportunity. We come so far with the treatment of this disease, which is why I can do what I can do. I can teach and drive and take care of my family. But there was a time that patients with MS were in a wheelchair in a nursing home by 40. You know, that wasn't that long ago. I'm talking about in the 80s, before we had no treatment for this disease until the mid-80s is when we first started our first treatment. So they get relief of their symptoms, and then at some point in life, something will trigger an inflammatory process, and the cycle will repeat itself. As scar tissue replaces the axon, that's when disabilities become more permanent. All right. So this is a healthy myelin sheath. So my nerve is traveling. The myelin makes it jump smoothly to speed it up and direct traffic. When you demyelinate, the message gets all messed up. Any myelin looks like that. Can't be good myelin, right? All right. So again, just to rehash, the B and T cells attack the myelin. Going, we're going to get you. They release chemicals that promote inflammation. And this attack is in the brain and spinal column because that's where white matter is. The antibodies fight the myelin, and it combines with other immune structures. We have gobs of immune structures, right? And they sustain inflammation, and eventually that can actually move into the meninges or into the gray matter. But that's usually a process. It doesn't happen fast and early in the process. Sclerosis means that it's had scarring and damaged the myelin. And so that's what gives you the residual signs and symptoms. Multiple means there's lots of little focal spots, right? It happens here, and it happens here, and it happens here. It's not in every myelin sheath, thank heavens. Okay, so again, it's a disease of exacerbations and remissions. So, you're working in a clinic. You've been asked to see DB in the clinic. He's been referred by his internist. He thinks his patient's having symptoms of MS. Kudos to that internist. Patients will have symptoms for months and months and not be seen by anybody with the mindset of MS because the symptoms are so vague and nonspecific, and we'll go over them shortly. He's a 25-year-old man who experienced increased urinary frequency and urgency over the last 2 months. Because his female partner had an STD, we thought he had an STD, right? So we treated that, but it didn't get better. Okay, the treatment didn't resolve it. So he's recently had 2 episodes of fuzzy vision, fuzziness in his eyes. He's associated with diplopia. What does that word mean? Double vision. Okay, double vision. And associated with diplopia and brightness. So like light sensitivity, lights seem unduly bright. Okay. He noticed ascending, numbness and weakness in his right arm. He can't hold objects in the last few days. So it sounds like it's getting worse, right? And more widespread around his body. And now he reports progression of weakness in his legs. So MS is an inflammatory disorder of the nervous system causing static, patchy demyelinization of the CNS. What does myelin do? Transmit nerve signals. And when demyelinization is
The
breaking down of that, MS is characterized by remissions and exacerbations. What happens to the myelin during an exacerbation?
It's being broken down.
And what happens during the remission? Regrowing or scarring or a combination of both. Right. Is he too young to get MS? No. Nobody's too young to get MS. Unless you're 5, right? Okay. What assessment data cause a physician to suspect MS? What kind of things do we have in there? It was progressive. Weakness.
Getting worse.
Getting worse.
It
It affects bladder, it affects his hands, it affects his feet, and the symptoms are neurologic. Numbness, tingling, those are paresthesias. That's what those are. Weird sensations, like the nerves aren't transmitting something normally. All right, and he says if it turns out to be MS, what's the treatment? I'm not going to ask you to answer that yet because we have more to learn. All right, we're going to come back to that question too. So, symptoms of MS, numbness and tingling. 63% of the patients that have MS have numbness and tingling in their extremities, feet, hands. When I was first diagnosed, you could draw a line. You know, the right side of the brain controls the left side of the body, left side of the brain controls the right side of the body. You could draw a line. And I was completely numb and tingly here and absolutely normal feelings here. I was like, okay, this is weird and it's definitely neurological. So my first step was to a neurologist. All right, then this shows you by percentage, 48% of people have difficulty walking. They have gait problems because of the coordination in the gait. Okay? Other common symptoms, dizziness, visual problems. A lot of patients have double vision and blurred vision. Pain doesn't affect everybody. That's only 20% of people really have pain. It doesn't hurt when you demyelinate. The central nervous system doesn't have pain receptors in it. And so it doesn't hurt when you demyelinate, but occasionally the demyelinization process will trigger some of the things that cause pain, and they will have paresthesias in the extremities. They'll have shooting pains, or there's a burning sensation that comes with one of the symptoms. We'll talk about in a minute. Bladder dysfunction happens. Fatigue happens to most MS patients when they're chronically tired. Muscle spasms. They have uncoordinated muscles, and then their muscles will spasm, and they'll have weakness. I consider weakness going with fatigue and all that. Okay, so what symptoms your patient has are going to completely depend on which nerve cell is demyelinated. If it's a motor nerve, they're going to have trouble walking. If it's a sensory nerve, they might have paresthesias. Remember, numbness, tingling, shooting pains. If it's a cognitive nerve, something about thinking and thought processes, it might be organization or memory or something like that. If it's an emotional one, they might have labile emotions. They might have inappropriate emotions. Labile means what?
Moving around.
All over the board. The arrow moves. I'm happy and then I'm crying. You know, or it's all over the board. Or spontaneous emotions for no reason. You know. All right. Fatigue. One of the largest overarching complaints of MS patients that they say causes them among the most disability. Fatigue can be bad enough that they just can't get themselves up and go into work. So it can interfere with their role, the role that they have in society as a mom or a grandmother or a nurse or a secretary or a truck driver or whatever their role is. It can interfere with that. It can be the most prominent symptom in everybody, in people that everything else is relatively low, but they just have fatigue all the time. So there are drugs we can use for fatigue. Dextroamphetamine, that's Adderall, that's our ADHD drug, right? Adderall. Amantadine, modafinil. Modafinil is a drug the Navy SEALs take to stay awake all the time. And Okay, well, I mean, they all have some kind of stimulant activity that keep the patient, give them more energy and allow them to stay awake. These are the common drugs. And I promise, as I want you to know them, I will clarify these for you more. All right? I want you to know, when we have slides, if your patient says, is there a treatment for my fatigue? I'm tired all the time. What's the answer? We have medication. Is it going to cure? No. It can treat your symptom. Okay? There's several options depending on which one works best for you. Right? And so that's what you need to know right now. Now, this makes sense. Amphetamine. Even if you know nothing else about these drugs, you should know what amphetamine means by level 3, right? You probably knew what amphetamine meant before you got to nursing school. Okay? All right.
Yes.
And then ADHD, have you done that in class? Has that been one of your... Okay, so Adderall hasn't been covered. These other ones may not have been presented to you yet, but there are drugs out there that treat this, okay? And if I want you to know more about that, we will talk about it. Okay? So, weakness in MS results from deconditioning of unused muscles because the nerves aren't telling that muscle to do its thing, right? So, if my body's going, I'm just not going to tell that calf muscle to move. And the person has a limp and dragging, and that muscle doesn't relax and tighten and relax and move the way all the other muscles in the leg do, then that muscle's going to become weak. And deconditioning can happen if somebody doesn't move adequately. So do you think that exercise and physical therapy can help keep patient keep their muscles conditioned? Yes. So would you think that an MS patient would benefit from that? Okay, so guess what? Manage it with rehabilitation strategies, work out, use a physical therapist, range of motion, strengthening exercises. Okay, gait difficulties. Gait difficulties. Ataxia. That when you see ataxia, that's a gait problem that patients have. That's what that word means. Okay? And weakness, spasticity, loss of balance, sensory deficit, and fatigue all contribute to that. If the person's vision is blurred, that could make you unsteady on your feet, right? If the person's legs are uncoordinated, weak, or clumsy, that would make you unsteady on your feet. Spasming muscles that tighten up and spasm and won't release can make you unsteady on your feet. Make sense? All right. Again, physical therapy and assistive devices, walkers, canes, braces can all help. But newly approved a drug to help with gait difficulties in MS patients. That's not a normal drug. That's a really new drug. You just need to know there's one out there, dalfampridine. Now, you guys, I want you to be really aware of suffixes of medications. If you have not been told that yet in nursing school, that is absolutely something you need to be clued in on. The generic suffixes in medications tell you what classification of meds they are. And that will always help you memorize your meds. Always. Right? Like Betalol, propranolol, metoprolol, beta blockers, OLOL, right? Drugs like that, it's always, your suffixes tell you what meds they are. Nadine, okay? There's classifications. We'll work on this. Again, if I want you to know that drug, I'll try you into it. I just want you to know right now there is a drug. Okay? Numbness and tingling are paresthesias. They can have numbness anywhere in their body where they just can't feel stuff. Arms, legs, often is the first symptom. Remember I said I was numb and tingly on one half of my body. That was my initial symptom. That's common. Also, the loss of sensation, pressure, pain, heat, cold can affect patients. Is that a safety issue? Yes. If I can't tell heat, I put my hand on the stove or in the scalding water. Proprioception, what's that word mean?
Where your body is, where your body part is in space.
Where you are in space. It's controlled by your inner ear, the vestibular apparatus in your middle ear. Tells you if you're upright or sideways or upside down, and it can get all messed up, and you may not have any clue. You may be it makes you dizzy. You can't tell if you're upright or walking straight or not. And then vibration sense. Vibration is something that we're acutely aware of and we don't even know it, right? Have you've been in a car and somebody's got music on really loud in the next car and your car's vibrating, you're like, right? Or people walking on the floor and you feel vibration, right? There's lots of things that our body's really aware of in vibratory senses. And it makes us very aware of what's going on in our environment. It's a safety thing. And so we aren't aware of that. Now, the other weird sign, I've got Lermity sign there. Lermity, I don't care which syllable you accent. But what that is, and a lot of MS patients complain of this, and they go, I didn't know what that was until I got my diagnosis. And what it is when they bend their neck for either stretching or exercise, like going to bend over like in a yoga class to do a downward dog, or to bend your neck to do some kind of stretch, they get a shooting electrical impulse down their spinal cord. It's called Lhermitte's sign, and it's common, very common in MS patients. Okay. Spasticity, stiffness. There's a lot of muscles that can become spastic, and then that makes their coordination difficult, and that can cause pain. That's also going to make you tired. Because when a muscle tightens up and it's spastic, it's using ATP, right? What's ATP? It's energy. It's the thing that makes us run, jump, laugh, dance, whatever, right? We get it from carbs is our most efficient thing that gives us ATP, right? Oxygen, carbs go into the cell, the mitochondria makes ATP, produces water and carbon dioxide and heat, right? And so, but if you tighten up a muscle and it's constantly tight, contracted, then that's going to use ATP. So can that make somebody fatigued because it's going to use up their energy resources? I think it's wildly unfair. It doesn't use enough to make you actually lose weight.
Yeah.
But anyway, that's something I'll have to take up with my maker. All right. So the treatment for that is muscle relaxants. This drug you need to know. I told you I'd tell you when it was really important. Baclofen, Lioresal. Baclofen. It is a drug that we give to relax. Now, so unfortunately, it also makes you sleepy. A lot of patients have baclofen pumps, where we'll have a pump that releases small amounts of baclofen into their body to continuously take care of the spasticity. Other patients dose throughout the day to take care of it. So it's just up to the patient if they need it or not. But baclofen is a drug. And then this, I told you, I would tell you if you needed to know it. I know this drug you may not know, but botulinum toxin A, even if you forget that part, Botox. So it is. Maybe I have an excuse to get facial Botox. My husband hasn't bought into that idea yet. I'm just looking wrinkled. Yeah, maybe insurance would cover it. Hey, I might have a deal here. Okay. No, but baclofen is far and by wide the more common drug we're using. Yes, ma'am?
What about Robaxin?
Robaxin?
Does that take once or twice?
It does, and some patients use it. I've been prescribed Flexeril once or twice. The baclofen is the most common one. Make sense? The other muscle relaxants can be used, yes. I don't want to say they're not used. These are just the more common routes. All right, vision. Blurred vision, contrast can be misinterpreted, loss of color, because after all, it's the ocular nerve that feeds the maculophobia that gives you clarity and color vision, right? Pain with eye movement. Nystagmus is when your eyeballs shake. It's kind of a weird neurologic symptom. Diplopia, double vision. All right. People who feel off balance, lightheaded, dizzy, they feel like they're spinning. It's that proprioception thing. And so they constantly feel like they just got off the roller coaster, quite often. Meclizine, that's motion sickness stuff, right? Meclizine, commonly used for that. Bladder problems. Bladder constriction controlled by the nervous system. Bowel function. The rectum controlled by the nervous system, right? So if you tag the wrong neuron, destroy the myelin, bladder and bowel function may be impaired. So it's usually the anticholinergic because of spastic bladders, right? Who's that? There's all kinds of commercials, you know, with people that have bladder, spastic bladder, right? Yeah. Anyway, that stuff. Oxybutynin, that's an desmopressin. Desmopressin is antidiuretic hormone. That's what that is. It's vasopressin, antidiuretic hormone, ADH. That's produced in what body organ? The pituitary produces ADH. We release it in a lot of different circumstances. Our kidneys use it all the time. But if your patient's having a problem with dribbling and incontinence, and we give you anti-diuretic hormone, we could make them not go as much, right? So, oxybutynin controls the spastic bladder. Desmopressin, is vasopressin, is ADH. Okay? All kinds of stuff we can give. All right, sexual problems can be common if you lose sensation, if you have motor problems, and if you're dizzy, and you have spasticity, and you have pain. That could cause any one of those things could cause sexual problems. Plus, the neurons are highly involved in sexual response for all of us, right? So if they're damaged, then that can affect that. So these drugs are like Cialis and Viagra, right? So especially for men, might have erection problems.
So, but would both of those be just for men, or would
No, actually, they said Viagra can help with women's sexual response too.
Answer my question.
Yeah, I know how. There is some research that says it's possible that Viagra can help with a woman's sexual response. It's not commonly given out there, but that research is kind of in progress. Keep your eye on it. You may see more of it. All right, constipation, again, if your neurons are messed up, you may not peristalse or evacuate the way you should. And you guys know what you do for constipation. That's like a level 1 and 2 thing, right? So you got Colace and Ducalox and psyllium. What's psyllium? It's fiber. It's psyllium husk. It's Metamucil. Thank you. All right, we get so used to generic names now that sometimes my brain goes, what's that trade name? Yeah. Bulk-forming laxatives, stool softeners, all those things, right? You know those drugs. I don't have to worry about you learning this. All right, cognitive changes. Half the people eventually have some side of cognitive change. So when I start not making sense this semester, just go, Miss Amerson, your MS is getting me. No, inability to learn, inability to remember, inability to organize or problem solve, inability to pay attention, or even you can't perceive the environment right. And again, that's vibration, vision, hearing, all those things can be affected. All right, pain. Again, 55% of people with MS have some significant pain. Half of them have chronic pain. The pain, what do you think we're trying not to give? Opioids, absolutely. A lot of times the pain is from spasticity. So the baclofen is commonly given to treat the pain of MS.
How does the pain present?
It depends on the patient. Muscle spasticity just causes pain in the muscles from being tight all the time. Paresthesias from the brain telling my legs or my arms or something to have shooting pain or tingling or numbness. Or, I've had one exacerbation once. It felt like I had a rock in my shoe, and there was no rock in my shoe. But every time I took a step, it felt like I had something there. It was so aggravating. It actually makes your foot hurt, right? And it's like But I took Advil. Tylenol may not work as well as Advil because Advil is anti-inflammatory. Tylenol is not, right? Tylenol can help the pain. Advil helps the inflammation.
Do they use gabapentin for this?
Gabapentin can be used for neurologic pain. Yes, it can be. But stay away from the opioids. All right, emotional changes. Depression is really, really common in people with autoimmune diseases in general. As we talk about lupus and rheumatoid arthritis and ulcerative colitis this semester, depression is very common in people with autoimmune diseases. These are chronic incurable diseases. It causes depression sometimes. So it's also, there's neurologic changes in the brain, changing neurotransmission, and that could cause the way you to change the way you feel. Okay? We're going to do depression next week. Irritability, pseudobulbar affective disorder, that's the labile emotions, laughing when most people are crying when most people are laughing. They come up and said, there was a horrible accident, your best friend just died, they may break out laughing. Okay? And they was going, really? Did you hate her that much? And no, it could be pseudobulbar affective disorder. All right? Now also, and it says, think about working with a family, because MS is hard on the patient, but somebody has to live with that person who's always spastic, always in pain, may not be able to walk, sometimes can't drive, and that person then now is doing inappropriate emotional stuff, might lash out angrily or cry hysterically, and so the family has stressors too, lots of stressors. All right, and again, clinical depression, I mentioned that in there with the other cognitive changes. So speech problems, slurring, dysarthria, slurring, loss of volume, that's right, can't talk loudly, dysphonia, okay? 25 to 40% of people in MS. You don't have to know these percentages. I give them to you so you know how common it is, right? How common it is. And then they might have slow speech with lots of breaks in it as they search for words. That might be scamming speech. Anyway, I'm modeling, not experiencing. Huh? Stuttering? Yes, stuttering can happen. Absence of speech, stuttering can happen. Swallowing problems, because of the nerves that are affected are the pharynx, the pharyngeal and swallowing reflexes, then that can happen. A lot of, then if that nerve is affected, then aspiration becomes an issue, right? All right, so multiple sclerosis. Again, autoimmune, usually female, often familial, ringing in the ears, hearing loss, nystagmus, which is shaky eyeballs, double vision, diplopia, blurred vision, difficulty speaking, difficulty swallowing, urinary retention or spastic bladder, constipation, weakness, paralysis, ataxia, and vertigo, right? There you go. All in one picture. I love those little memory pictures. They help me learn. All right. So here's our patient. Let's go back. Yeah, let's go back to my patient. Maybe we can answer some of those questions now. I can't remember. I think we have to go forward a little more. Okay, we did the assessment today. What's the treatment? And we know his symptoms can be treated, right? We haven't got to disease treatment yet. It's coming. So, sorry as I flip back and forth. All right. I'm going to come back to this. Although, wait, it kind of fits here. He confides in you he's been depressed since his parents' divorce. We just talked about that, right? He says at the onset of the symptoms, he says that my girlfriend hasn't been faithful to me, but he's afraid to live alone because he said if it's MS, she's going to leave me and I'll be all alone, sick, not able to take care of myself. What do you do with this information? He says, I've been depressed since my parents died. I have this chronic illness possibly.
Refer to a therapist?
We have to tell the healthcare provider about it. We need to do a depression screening on him. We need to see if he's got other issues related to his depression. We'll talk more about that next time. But we have to follow up. When somebody says, I'm depressed, I've been depressed a while, my girlfriend's cheating on me, I have this chronic disease, something else happened in my life, we have to intervene. Yes, ma'am?
Would this be the nurse's responsibility or the case manager's responsibility?
Well, it says you were in a clinic. So if you're in a healthcare clinic, a lot of times the nurse is the person the patient's talking to. So if the patient reveals something to you, it's your responsibility to get it to the person who can do something about it. If you are the case manager nurse, then you're going to do something about it. If you're not, and there is a case manager or a provider, you have to share that information with them so they can get appropriate treatment or referral. Make sense? In a clinic, that's often you. In a clinic, that's often you. Even in home care, the RN is often the case manager, right? In hospital settings, case managers, often there'll be a couple of case managers on the floor that are RNs or social workers, and then other RNs help them with the discharge plans. This guy's outpatient in the clinic. Okay? So the psychosocial issues, he has some things that certainly need to be monitored, right? So, obviously the depression. Is there anything else that you think needs to be monitored in his psychosocial concerns? Emotional, but if he has progression and cognitive changes, his emotional status, the fact that he's going through grief after his loss of his parents, sometimes just depression isn't the only thing that happens. Sometimes there's dysfunctional grieving that occurs. We don't want to watch that. I just want to follow up with him on his emotional status. I don't want to let it go. Okay. Which of the following statements made by a patient? Remember we said we throw anti questions in periodically for his test taking?
Yeah.
We'll do this off and on. Okay. Are you guys okay? Am I killing you?
No.
Okay. All right. Well, I need feedback. So if I'm going too fast or making no sense, somebody has to say, stop. Clarify. All
I
right.
do have a question on the
Yeah.
on the you're talking about somebody who's lost his parents and his partner possibly
And a
or
chronic illness.
and a chronic illness. Don't we have home, not just suicide, but home health issues with
He
their
mu-
immobility issues?
He hasn't got rid of his girlfriend yet because he doesn't want to live alone. She's
Okay,
still there.
yeah.
But we certainly might. And that's something. If he gets rid of the girlfriend, he needs home care. And even if he has a girlfriend, and she's that kind of girlfriend, she might not be worth anything, right? I mean, I don't know. I don't have any idea what kind of person she is. The case study just said she cheated. So, So we'll find out about his support systems and what kind of support he has. He's lost his parents, he's lost his significant other probably. He might not, but if he has a brother that lives next door, he might be okay, but he might need home help. Excellent for home health referrals. Okay, so NCLEX. Which statement made by the patient with multiple sclerosis alert the nurse that they need additional instruction about their disease? Reducing stress will reduce the severity of my symptoms. I will limit exercise to reduce fatigue.
I have a question about that.
Do you limit exercise to reduce fatigue?
No.
What's your question?
If someone was fatigued, would they need to be resting during like an acute phase? Like
You
if
might,
they're having acute
but
fatigue?
remember, all true, all false. This is select, all apply. Every answer has to be true, false. When somebody's suffering fatigue, physical exercising condition is something we recommend for them.
More information.
Well, if you need more information, then you don't have the information. It's probably false. Hang on a sec. Yes.
The question is asking what's the last and last that the patient needs more instruction. So I think
That means which one's wrong.
yeah, so that one is wrong.
This one is
I will
wrong.
limit exercise.
This one actually is wrong too. Stress brings on symptoms, but reducing stress doesn't make symptoms go away. See what I'm saying? So if I get really stressed and I start dragging my foot, when my stress is over at the end of the day, that's not necessarily going to get better, right? My myelin now has to heal to get me better.
But if you reduce the stress, would it
Maybe it may enhance
keep it
healing
from
time.
getting
Keep it from getting worse. Yeah. It didn't say reducing stress can help prevent an exacerbation. That's not what it said. Don't read into the question. Don't read into the question. Okay. A low fiber diet will prevent problems in my bowels. He's most likely to be constipated. High fiber makes everything improve, right? No, this one's wrong. So
For steps for further
he needs more education. So we would select this one. We would select this one. We would select this one. It's important for me to inspect my skin every day to make sure there's no injuries.
Yes.
Not really.
What?
Not really. Why?
What if he has
the pressure and the heat and
If
the...
he has, okay. So again, depending on your symptoms, maybe if he's numbness and he can't feel anything, like the diabetic with paresthesia we told him, he doesn't have healing issues though. Healing is not an issue. You can stub your toe and you're going to heal. You don't have diabetic problems with
you
healing.
can't feel that you cut it.
But
If you cut your toe on something and you can't feel it,
you might get infected if you don't treat it. Okay, I'll go with it. So is this a right answer or wrong answer? Then it makes it okay. Do I need to give him more teaching? So we don't want to collect, we don't want to choose it. A hot shower before bedtime relaxes my muscles and relieves pain.
Yeah, false.
It's actually not true, and I haven't got to that point to let you yet.
Heat increases
Heat makes
inflammation.
MS worse. Heat makes MS worse. So hot showers are probably not in their future. It's a select all that apply. So choose that one. He has problems. Choose that one because he needs to learn more. He needs to learn more. He needs to learn more. Right? I'm okay with that, and he needs to learn more. It's not 3. Somebody told you it was 3. It's not always 3. That's one of the single biggest select all that apply issues we have coming into third. So I don't know where you learned it, and hopefully it's gone away.
Most of
I
them
think
start
that
early.
from the second semester, it usually was like 3 to 4 answers.
Yeah, I know.
But
60%
now,
of skills need to balance them out.
3. That's half. Let's make it. Okay. Gotta be right. All right. And am I okay to push through for 30 more minutes and give you your lunch break? So MS. There's 4 different major types of MS. Okay? There's benign MS, where a person has a single episode. It's clinically isolated. They go through remission, and they never have another symptom their whole life long. If you're going to get MS, that's the kind you want. Get in line for that one. I don't think you get to choose. Okay, relapsing remitting is absolutely the most common kind of MS. That's the kind where they get exacerbation of symptoms, there's some healing, they get better, they get another exacerbation, it heals, they get better. There's a variable time within exacerbations, but they have multiple episodes throughout their life, It gets worse, it gets better, and then move on. It doesn't always go back to baseline. It's like this. I had an exacerbation, I got better, had another exacerbation, I got better, another exacerbation, I got better, another exacerbation, I'm not making my line go up enough, but they're getting worse. Their baseline is continuing to get worse. Each time it gets a little worse. And I got good grammar. Okay. And then there's primary progressive. If I have to not have one, this is the one I never want. Okay? Because that one, you have an exacerbation, and you keep getting worse. You never really get better. It never really gets better. A lot of patients have an exacerbation and it just does this. Okay? Those are the patients that we see in the inpatient setting the most. Because those are the patients that are having ventilatory assistance, in wheelchairs, need bladder training or catheters, because they're just so much worse. These are the patients we see most often in healthcare. Then secondary progressive is a patient that had relapsing remitting for most of their life. After about 15 to 20 years of relapsing remitting, a certain percentage of MS patients become progressive. So instead of getting better each time, now then they will switch to this path. Okay? I think I have a picture in here.
So with relaxing?
Huh?
With relaxing and remitting, even if it happens all your life, like what's the difference between having relaxing remitting for like 20 years and having secondary progressive?
Well, for the first 20 years, we say, oh, you have relaxing remitting. And when they become progressive, we're like, oh, yeah, you've changed. Secondary progressive. Okay, benign, one episode, nothing. They might, 30 years later, have another one, but there's no come and go getting worse each time. Relapsing and remitting, most common. I have an exacerbation, I'm fine. I have an exacerbation, I'm fine. Then this person looks like they might be, they're still relaxing and remitting though. Secondary progressives here, relapse, remit, and then look, now I'm really getting worse. This one's getting a lot better each time, even though the disease continues to progress. And then primary progressive, it started and it just kind of got worse. It never got better, right? So, you're not a diagnostician. You don't have to diagnose somebody. But if a patient asks what it means, it's helpful to be able to tell them. It's helpful to be able to teach, right? Helpful to know what to expect. All right. After diagnosis, the number of exacerbations in the first 2 years indicates a lot about their prognosis. If they have more than 2 exacerbations in that first year, their prognosis tends to be worse. Prognosis means how they're going to do on down the road, right? Most of us patients live 35 years after diagnosis. 93% of them have an average lifespan. And you know what? Those secondary progressive patients and primary progressive patients are the ones with the shortened lifespans. Because once you start getting worse, then you're at risk for aspiration pneumonia and bed sores and immobility issues and things like that, right? Death is due to complications of what I just said, immobility, pneumonia, and UTIs. Because most people don't die of UTIs, but UTIs is the most common source of sepsis, which is a systemic infection that causes shock and damage to all your organs and has like an 80% mortality. Okay, so exacerbations come on and develop over hours or days. They're like, okay, wait, I'm getting worse. And sometimes it's just that little piece that gets worse, and then it's like, oh, this is continuing. So it's getting a little more. So they're exacerbating. They will, once they peak out, and this is what's gone bad, so 2 days later it's like, okay, now I'm dragging my leg, I can't swallow, I've got double vision, whatever. That will last 2 weeks, 3 weeks, so a couple weeks. And then the healing will start to occur. It can take a couple months for that healing to occur. If the symptom persists over 3 months, we think that's going to be one of these deals, where you exacerbated and you got a little worse. The symptom didn't go away, so you get a little worse with that exacerbation. Does that make sense? That one's going to stick around. All right, so what precipitates exacerbations? Excessive fatigue. MS causes fatigue, but excessive fatigue will precipitate an exacerbation. Increased exertion, doing a whole lot of stuff that's putting a lot of stressors on you physically, mentally, emotionally. Extreme heat and extreme cold. Heat is a much bigger culprit than the cold is. But extremes in temperatures. So Texas in the summer is hard on an MS patient. They actually have cooling vests and cooling things they prescribe to people so they keep their core temperature down. Infections can, because that stresses your body, right? Stimulates your immune system, tells it to go attack something, and your body's going, okay, I'll attack my nerves. Trauma, so if you're in a car accident, break a leg, have lacerations, injuries, you're in the hospital, that can be enough of a stressor to stimulate an exacerbation. And pregnancy, unfortunately, can cause an exacerbation.
I thought you had a reduction in symptoms during pregnancy, though. And then
I remember reading that.
But
Like a rebound
after
after.
pregnancy, you'll get worse.
After pregnancy.
Yeah.
Pregnancy will exacerbate
Later.
symptoms. During the pregnancy, you're right. A lot of women, especially in those early trimesters, feel great. You learned that somewhere along the way. Where have you done MS before in this program?
No, it was in the reading.
In the,
It was in
In the
Lewis.
reading.
oh, huh.
Yeah.
Usually on the initial MS, usually my students come in like, they've heard of it and they know about it, but not a lot about it.
Something else.
Some-
It was an exemplar.
Yeah, it was during first semester. It was just
Whatever, yeah, no, it's fine.
Yeah, whatever.
Not like this, not as much.
No.
Okay. All right, so diagnosis is difficult. The patient comes in and says, I'm really fatigued. I'm tired. I'm clumsy. Got blurred vision. Right? I come in with blurred vision and say, go see your optometrist. I come in,
during the day.
I'm clumsy, yeah. Don't have body on your cornflakes, right. So, there's going to be all, and they're going to go, well, if you're tired, rest. Go do some stress response therapy to get rid of the stressor. So sometimes it takes months and months for patients to get diagnosed. One thing, we start looking for things. If they get overheated, do their symptoms get worse? That's a trigger. We can do a lumbar puncture, look at their cerebrospinal fluid, and it will have elevated levels of gamma globulin in it. And we also will do an MRI, and they'll have white, patchy lesions. Most of them are around the ventricles. But they can be, again, in spinal column, thoracic, sacral, cervical, and cerebral areas. And then we have to, MS is a disease we diagnose by ruling out other stuff. Symptoms of lupus are almost the same. So we would let's check lupus. Let's check Lyme's disease. Let's check secondary syphilis. Let's check the other autoimmune diseases that might have more definitive diagnostic stuff. And it's like, there's nothing else. Probably MS.
What is the similarity with the Lyme disease?
Huh?
What is the similarity with the Lyme disease?
The fatigue and the neurologic symptoms. Gait problems, fatigue. Lyme's disease causes a lot of some neurologic symptoms, paresthesias with it.
On the MRI with the white matter lesions, do they get inflammation or fluid or any edema?
They use contrast, and if it lights up, then there's active inflammation on that myelin.
Okay.
And that's how they find it. Because it's not like an MRI shows inflammation. Inflammation is not visible on an MRI. They have to use the contrast medium because it'll go stick to inflammatory stuff. All right, so white lesions from scarred tissue that stuff stuck to. There's an MRI. You can see the white patchy lesions. All right, so treatment is symptomatic and supportive. What symptom they got, that's what we treat, right? We also need to teach the patient about their disease, about their progress, what exacerbates and remits it, how to stop having as many exacerbations, right? Teach them coping skills and teach their family coping skills. And whatever med we prescribe for them, they have to learn their med, right? So there are treatments for MS now, a gazillion of them. I want you to know a couple. I'll tell you which. Don't go, when you see the list. Still, okay? Medications are injectable and injected. That's just crazy. Injectable is the patient gives them to themselves, sub-Q or IM. Oral is a pill. I hope you understand that. Injectable, I should have put infused. These are IV infusions. That's my fault. I should have put infused. These are IV infusions. So the first drugs on the market in the 80s were the ABC drugs, Avonex, Betaseron, and Copaxone. interferon beta 1A and interferon beta 1B. Interferon. That's the base name of that drug. You need to know interferon drugs. We use them in cancer. We use them here. We use them in hepatitis. We use interferon drugs for a lot of things. Interferon drugs were originally grown in a lab to treat colon cancer. And what we found out is, guess what? They didn't. But they had all these other really cool uses. And so we did discover that the interferons help to reduce the exacerbations of MS. So patients who take interferons Avonex is IM once a week. Betaseron is sub-Q every day. Copaxone is not an interferon, but it's sub-Q every other day. So these are injectables. But the interferon drugs, they take them and they have less exacerbations because of them. Okay? That's what it is. Those drugs cause flu-like symptoms. They have really the side effects. The patient feels like they have the flu for the first month they're on the meds. So who wants to stay on a drug that makes you feel tired and sweaty and achy and headache and right? I feel like I have the flu. So we say take it at night, sleep through the worst of the symptoms, and stay with it because eventually that'll get better. They also have really bad site reactions. They get these red globular lumps that stay red and inflamed for weeks after the injection, and nobody likes that either. They also, one of the problems with the interferon drugs is patients can develop antibodies against the drug, so they can become immune to that drug helping them. And that will actually cause them to exacerbate. So we have to periodically check them to make sure that drug is still effective and they don't have antibodies to the drug. Yes, Stan?
Is this just
Ms.
the
Wilson, right?
Yes, ma'am.
Okay.
Is this just the A and B or the A, B, and C?
And all the interferon drugs can do that. Okay, so it's really, I want you to recognize on the test, if I say interferon as the group of the drug, you need to know flu-like symptoms, autoimmune to the drug itself, and that it decreases exacerbations or remissions, right? This, you got this, right? All right. Then the oral drugs, excuse me. Tecfidera has certainly become the most common oral drug we use for MS. It's got a lot of complications and problems itself, but that's the most common one in that list. And in the injected drugs,
What did you just say? I'm sorry.
Tecfidera, dimethyl fumarate, natalizumab and ocrelizumab. Look at lizumab. Right? Same family of drugs, right? Ooh, look, umab, lizumab. Oh my gosh. I see suffixes in common. So if I see an MS drug that says lizumab at the end of it, I'm going, ooh, we're giving it by IV. These drugs are all TNF inhibitors, tumor necrosis factor inhibitors. TNF, tumor necrosis factor, is a part of our immune system that's supposed to help our immune system be more active. Right? But the problem with MS is autoimmunity. I'm being way too active against myself. Did you have a question? Similar. It's similar. It's in that family. But they're different drugs. They're the MABs and the FABs. MABs and FABs are always immune suppressant. They're immune suppressant. On the commercials, we'll see other drugs with the MABs and FABs ending in this unit. On the commercials, get a TB test before you start it. Because if you have TB, you're going to immune suppress, you're going to get worse. Right? And it'll say things like, oh, let's make sure you don't have any other comorbidities going on. Make sure you're screened for cancer. Make sure you don't, because we don't want to suppress your immune system if you're high risk for other problems, right? Okay. So these drugs are infused by IV. Most of them, once the patient's got a therapeutic level, they can get once every 6 months, or once a month, or once every 6 months. They'll get an infusion. And the patients sometimes like that better than self-injection every night. Just depends on the person. One of the things we've discovered with Ocrevus and Tysabri is that actually shows some healing of the lesions. Patients who are on those drugs get some function back after a while, which is really cool for that person.
Which one is that?
I said ocrelizumab and natalizumab. Those two have showed some healing.
Okay, the other thing you said they prefer that one. Do they not get the flu-like symptoms with those?
With these, Some of them do, but not so much. It's the interferons that are known for that. Patients they feel crummy after the day after the injection, after the infusion. They feel horrible that day. And they have some really bad infusion reactions. We're going to talk about it in a minute. Okay, other meds we give. Immune suppressants. They're autoimmune, so they're hyperimmune to themselves. Before we had all these great drugs for MS, immune suppressants were all we had. So we gave drugs that we use for cancer and organ donation that suppress the immune system in an effort to try and eliminate symptoms. They're okay. If nothing else works, they're a good thing to do. They have side effects and we don't always like. And there's just problems with some of those drugs. So now you're going to see the other drugs that I just mentioned on the last slide given much more commonly. But if the person's been on interferon for a long time and then we move them to Tysabri and nothing's working, then sometimes we'll add one of these to their treatment regime, methotrexate or Cytoxan. All right. Immune modulators. Interferon, we just talked about that. This is the category. Immune modulators for those ABC drugs. Interferon and glycemic acetate, dimethylfumarate. Lizumab. There's Lizumab, right? That one is so cute. But don't worry about it. That's not one of them I want you to know necessarily. So. Okay, so interferon works by decreasing the destruction of myelin. We don't exactly know how, but we think it makes the antigens that stimulate that go away. Don't you love it? I took glycemic acetate for like 15 years. I took this drug for about 10 years too. And it was like, we don't know how it works, but take it. I'm like, it's going to make you feel like you have the flu, you're going to have horrible whelps all over your body, but take it anyway. And I was like, okay. All right. So again, side effects of the interferons, flu-like symptoms, give Tylenol if that's what they're experiencing. People on interferon and glycemic acetate often get suicidal ideation because depression is a big side effect of those drugs. You have to watch that. Because it's immune suppressant, it can suppress their white count, leukopenia, that's what that means, suppress white count. Watch their liver function because lots of drugs mess up your liver. Okay, how do we know if these drugs are working? The only way we can tell, what are your signs and symptoms and how often are you exacerbating? We'll do an MRI every year to see if it's getting worse or better, right? And these drugs, these are self-injected drugs. Remember, interferon and Capexin, they're giving it to themselves every day or every other day. They have to be awake, alert, cognitively aware patients that take care of themselves, right, to be on these drugs safely. And they're used for relapsing or remitting. Glycemic acetate, again, those whelps all over the body and suicidal ideation. We don't know how it works, but it decreases the exacerbations. Ocrelizumab, Ocrevus. It's a Lizumab. It ends in mab or fab. It suppresses the immune system. Level 4, the teacher calls them mobs. I call them mabs. So next semester when she says mob, you're going to go, that is it. Okay. That's just a pronunciation thing. I'm from California. I do everything right. All right. Once they're on these infused drugs, they can have these infusion reactions up to 24 hours. Polymorpholeukocytosis. They get patchy lesions in the brain where it destroys brain function. It's a horrible infection of the brain that decreases cognitive functioning. It's almost always fatal. And so we have to really be careful with these patients on these mabs and fabs. With the Lizumab drugs, but Ocrevus probably one of the better ones to give. And then what we'll do is we'll bring them in, do all that check. Get your mammogram, get your prostate-specific antigen, get your hepatitis screen, get your TB test, get up to date on all your vaccines, right? And then we'll start you on this drug. We'll give you an infusion. Come back in a couple weeks, have another one. Now you're at therapeutic level. But every 6 months, come in and get another one. And that should keep you okay. Okay. Other meds. We talked about Lyorcel. That's baclofen. We talked about that for muscle spasticity, right? Diazepam. That's Valium. It's a muscle vitamin D, right? It's a muscle relaxant. Dantrolene, a muscle relaxant. Botox. Yeah.
Paralytic.
It's a toxin that kills people if you eat it, but now we inject it into our body for some reason. Okay. And then modafinil, that was the one of the many anti-fatigue drugs I mentioned. All right, so what do we do about managing relapses? Severe relapses are considered severe if they lose vision, have extreme weakness, poor balance, can't walk, and they can't get to work, or their safety's impaired. Right? Then we go, oh wait, this is a bad exacerbation. And what we do with that, we give them 3 to 5 days of high-dose corticosteroids. What are corticosteroids?
Anti-inflammatory steroids.
Where do we make them?
Anti-inflammatory.
They're anti-inflammatory immune suppressants. Made in our adrenal gland. We have our own natural ones, right? But then we've synthesized them in lab and made some fake ones too. Cortisol. That's what we make in our body, right? It's Solumedrol, Decadron, Prednisolone, right? Those are steroids, okay? What we give is Solumedrol. Now, anybody had one of those Medrol dose packs? You can say you take a little bit every day. Okay, each one of those little pills is 2 milligrams. Okay, that's how much in the Solumedrol dose pack is, okay? When I say high-dose corticosteroids, they get a gram of Solumedrol every day for 3 to 5 days. Okay? In the Medrol dose pack, the whole pack only has like 20 grams, okay? 20 milligrams.
What do diabetics do for that, though?
Take more insulin. Because you're right. Corticosteroids are problematic in side effects. They are glucogenic, right? They cause fluid retention.
And infection.
They immune suppress you, so you're more likely to have an infection. Okay? If you're on them for a long period of time, they build up fat pads, moon face, buffalo hump. They change your protein and carb metabolism, so your legs get spindly and you get round stomachs with stretch marks from the fat lay down. They cause labile moods. They cause you to cry or scream or in high dose, they can cause psychosis. They cause a decreased libido. They cause hair to grow where it shouldn't grow. They cause breast growth in men. Okay. I always say, if you are retaining fluid, cause acne, your acne's going up, you're having psychotic episodes, mood swings, a buffalo hump, a round face, weight gain, of course your libido goes down. In the midst of all that, who wants to go have sex, right? All right, so 3 to 5 days of high-dose corticosteroids. Then we have to taper. If you're having high doses for a lot of days, you might have to taper, right? Because corticosteroids in high doses shut your own adrenal gland down. So usually they give you a taper dose then for a week, like cutting it back over the next week. Okay? So high-dose Solumedrol, high-dose prednisone. ACTH can be used, but mostly it's Solumedrol. Solumedrol is what you see 90% of the time. Solumedrol is the one you need to know. Did you get that?
Yes.
All right. Plasmapheresis. I've got 2 minutes to get through this and get you to lunch, right? Plasmapheresis. This is a process where a patient goes in. You guys have seen blood, like donation of blood, where they go and they pull blood off, right? It's a similar process. The patient goes to a plasmapheresis center. They put 2 IVs in them. We pull their blood out. We run it through filters. We take out antigen and antibody complexes. Antigen, antibody, right? So the process of the very thing that causes inflammation, we remove those antigen antibody complexes. Remove those T cells that are reacting to things. And they give them back the rest of their blood back. We'll give them their red cells, their white cells, their plasma, all the other stuff that's good, give it back to them. Just take out the stuff that's causing the inflammatory response. It takes a couple hours. So it separates the plasma and cellular components, and we take out of that plasma what we think is problematic to the patient. We use this for rheumatoid arthritis, we can use it for lupus, we can use it for MS. There's lots of different diseases we use this for. Okay? But because they're sitting in the chair, we're pulling fluid out of them. We put saline or Ringer's usually saline back. Fresh frozen plasma can be given back because we are taking volume out, right? So what we usually see: hypotension because of volume loss or a vagal reaction, The products that we give back to them often have citrates in them. Every time we give somebody a blood product, it's got a preservative in it that's called a citrate. And some patients have reactions to that preservative. So in plasmapheresis, if they're sensitive to those preservatives in the blood products we end up giving them back, then that might cause a reaction of some sort. That plasmapheresis also drops their calcium levels. And hypocalcemia can give you some symptoms like paresthesias, headaches, Bostex and Trousseau's. Anyway, and in plasmapheresis, it's treated like when we're dealing with blood products. We're taking blood out, we're administering some blood products back to them, and so we take all the due precautions that we do with blood transfusions. The patient might get a dose of Benadryl beforehand. The patient's going to have signed consent forms. There's a lot of process. Okay, but it takes away the antibodies. It takes several hours, and you have to monitor for side effects.
Is this different than like when I work at Plasma Center, so is this different than when they like donate at my center?
Yeah, somebody's donating plasma, and at your center, is it a pay for product center? Okay, your plasma is sent for research.
Yeah.
We can't actually give that plasma or to a pharmacy somewhere. It's not actually given as a plasma product back to a patient in the hospital. If you go to a blood bank where you do voluntary blood donations that they screen differently, that is the kind we can use on patients, and that's what they'll get back. But plasmapheresis pulls the plasma out and gives them the other stuff back, right? With yours, I don't know, do you do that there too?
I mean, it's
I can't remember.
like the blood is just pulled out with one needle, the plasma drops into a bottle, and then
You centrifuge it, yeah. You spin it down. Yes.
How often is this usually done?
Every 6 months probably, or during times of acute exacerbations.
Would you see an AV fistula with this?
No, not usually. It's not done that often. It's not like dialysis where the patient's coming in 3 times a week or 4 times a week. They're coming in once every 6 months, so 2 needles will do. And they both could be venous. So. All right. Clinus prescribed interferon B indicates the understanding of patient teaching when he says, I may experience flu-like symptoms while taking. I feel nausea while taking. I will inject this into my thigh muscle. I may experience a rash. Interferon is given subcutaneously, so it's not into the muscle, and flu-like. They get injection site reactions so they don't get a rash. And subcu and nausea isn't one of the symptoms, but flu-like symptoms, aches and pains and headaches and fever. All right, I have to give you a lunch break, or else you guys are going to drop your blood sugar, have headaches, and start being mean to me. So
Was that true, false, false?
this is a single answer question. A is the right answer.
Okay.
It didn't say select all.
The first.
Huh? Oh, what's wrong with it? I'll stop it. Yeah. I stop it when I have to.